So hi, good morning. I'm Cindy, the nurse practitioner at the Heart Function Clinic. Some of you maybe see me wandering around in the emergency department lately, looking for patients. So earlier this year, we were awarded a research challenge grant, and we're looking at a pilot study to assess the feasibility of providing a different alternative model of care to reduce ER visits and hospitalizations for the vulnerable population, so patients with substance use disorder and or mental health needs who do not come to the clinic or unable to come to the clinic. So the purpose of our study was to explore the feasibility of a different alternative model of care for patients with heart failure who have comorbid substance use disorder and or mental health needs. There we go. Okay. Basically, so the two research questions, what is the feasibility of providing a specialist care by myself, a nurse practitioner, using face-to-face and or telephone support with the primary care providers for patients with in our population, and what is the effect of this alternative model on clinical outcomes? So a bit of background. Back in 2016, we looked at our no-show rates, and generally we have a 10 to 20% no-show rate to the clinic. And what the characteristics that we found, that they're younger, more likely to live alone in shelters or SROs, have documented mental health needs, substance use disorder, and incidentally, when we looked even further, the high number of ER visits, many cardiac related, which I'm sure you guys are all well aware of and see. So we went further and we looked, out of these patients, we looked at 10 randomly selected, and we found 148 ED visits, many cardiac related, so often coming in with a shortness of breath, chest pain, 46 hospital admissions, and between these 10 patients, when we added them all up, there's 345 days in hospital cardiac related. So currently, when patients get referred to our clinic, they have to go to an intake with the RN where they get education. That could be an hour. And then a couple weeks later, they come and see the cardiologist, which those visits can take about 2 hours. So and this happens at each subsequent visit where they can wait for a long time. Some may show up initially and then drop off and stop coming altogether. So when we looked in the literature further, we found that this model does not work well for these type of patients. And we found that the care should be flexible and closer to the patient's community. So thus we came up with our pilot study. So the inclusion criteria, basically, they have to live in Vancouver, have a primary care provider who wants to participate, have substance use and or mental health needs, and they've either failed to attend, or when we triage them, if they're deemed to be high risk no-show, then they'll come over to me. Exclusion, they prefer to attend the clinic, end of life, or unable to contact the patient. Now, we've been running since February, and we're going to be revising because we're actually we've had 11 referrals, but half of them actually, with support, we've been able to get into the clinic. So we're going to revise a bit. So and some of them don't have a primary care provider. And so what I'll do is I'll talk with our social worker and see if we can get them set up with Pender Health or downtown, one of the community clinics down there, which helps. So what will happen is when I get the referral, I call their primary care provider and let them know that they've been referred, because sometimes they don't know that they've been referred to the clinic, and see if they want to participate in the program or in our study. And of the 3 GPs that I've called so far, they have declined and want them to come into the clinic. So we booked the patients to come in, and not surprisingly, they don't show. So in the process of recontacting again to see if we can come up with some different type of care plan for them. There was some interest, for my behalf, of going down to one of the community centers and having a day where the patients could come and see me down there. However, clinic space is very limited as well down there, so that's not an option, unfortunately. And my physician support is Dr. Cowan. And So what we would do when we get the referral, we look at the pre-test from date of index visit and post-test. And these are the things we'll be looking at: the number of ER visits, number of unscheduled admissions to hospital, and total days admitted. In post, we'll be looking at a few more parameters. I'm not going to go through them all to the limit of time. And our recruitment we're hoping from you guys, medicine floors, primary care, and cardiology, rapid access clinic. So the only thing would be just if you guys have these patients that you think would be suitable, just refer them to our clinic and we'll sort it out if they're candidates or not, or how I can work with getting them a primary care provider and that. So, any questions or suggestions? Yes.
Have you looked into why those patients are coming to clinic? I know they got demographics of mental health and substance, but it's often the mundane things like taxi cabs.
From coming, yes. And what we didn't look specifically at that, but what I've noticed, and actually probably in the last 6 months, my total population client list has gone up about 20 to 25% are patients with substance and mental health. And what we find, obviously, is if they can come with an escort, and we can provide them taxi voucher, or we prefer taxi vouchers the odd time, but generally bus tickets to get them to and from appointments. Yes. Yeah, and actually that's what I was doing last week, because there was, I can flag with Sarah, so I've been emailing and saying, hey, this patient's been referred, can you flag in your system so when they present that we get contacted? And then I try my best to get down there and just introduce myself and say, hey, this is who you'd be seeing and why. So we'll see this morning, because the patient I saw last week that I'm trialing this with is supposed to come see me this afternoon, so fingers crossed.
I'm surprised Trevor was okay. Trevor's usually this happening.
Yes, I do have a work cell number. What would be the...
Are there options? But Thursday night's a good night. Wednesday's a good night. But not like a...
Yeah, and generally, like when I pop down and see them, that I will come down with an appointment. Like that's what the plan is, because that's, I'm trying to get them back and get them the information, especially if you don't know where they're going to be. So there's a few that I've trialed that with, and I'm supposed to see them this week. So, yeah, but for sure. I think the best would be to contact me, and then I'll sort it out. Yeah, for sure. Yeah. Yeah, sorry. Any questions? What's up? Good. Okay, thank you. And send me the referrals.
Perfect, so just thank you. Okay, great. Thanks for having me. We were actually supposed to present at the last rounds, and I had Mark Hull here with me, but we ran out of time, unfortunately. So last rounds, they got the PrEP version of this, and I'll be giving the nPEP version of this, but I can maybe give a few points at the end with regards to PrEP and try to answer any of your questions. Mark and I were going to speak just because there are new guidelines for nPEP and PrEP, and we wanted to make sure that everybody was aware of them, and the IDC had a few concerns about referrals that have come to them, so we wanted to touch on that and make sure everybody is clear on the process. So a few years ago, we did a study out of our department here at St. Paul's where we looked at patients who presented after a potential HIV exposure, whether it be an occupational exposure, so a needle stick injury or a mucous membrane splash, or a non-occupational exposure, so a sexual encounter or needle sharing. And what we wanted to know was how well the physicians in our group did at treating these patients based on the CDC guidelines, because those were the standard at the time. So if somebody came in and they had an occupational or non-occupational exposure that was deemed high risk based on the CDC criteria, did they correctly get prescribed PEP? And similarly, if they had a low risk exposure, were they correctly discharged without the medications? And one of the biggest findings was that among those who presented after a non-occupational exposure that was high risk, so a sexual encounter or needle sharing that was high risk, more than a quarter of those patients did not get PEP, so they left without prophylaxis. And that's a large number, and it's also significantly larger than the number who presented after a high-risk occupational exposure who got PEP. So there's a big difference there. And it's really concerning because essentially all new cases of HIV come from non-occupational exposure, so sexual contact or needle sharing. In fact, in the last 20 years, there's only been one documented case of HIV transmission from an occupational exposure. So all cases are coming from non-occupational exposures. So if we skip ahead a year and a half or so, the CMAG published the first ever Canadian guidelines for HIV PrEP, which is pre-exposure prophylaxis, and non-occupational post-exposure prophylaxis. And this project was headed by Mark Hull, who's one of our ID specialists, as well as Daryl Tan, who is an ID doc at St. Mike's in Toronto. So that was published in CMAG, and then in this year, in January of this year, Mark and Daryl and I published a review article in CGEM looking at nPEP for emerged physicians. So it's basically an ER primer, a how-to on what to do with patients who come in after a non-occupational exposure. So I'll basically just take you through the algorithm for the new guidelines for us, and then I can direct you to where it's posted in the emergency department. Really, when you see a patient who's come in, there are three things you have to think about. And the first is that they have to come in within 72 hours of the exposure. If they're outside of that window, there's no indication for post-exposure prophylaxis. If they're within the window, there are two things to consider. The first is the risk that the source actually has transmissible HIV. And the second thing is to consider is the risk of the exposure itself. How risky is it that they would have gotten HIV from that particular exposure type? So in the guidelines, they break down source exposure risk into three categories. And remember, this is the risk that the source has transmissible HIV. So substantial, low but not zero, and then negligible. So those who are considered to have substantial risk of HIV that is transmissible are those who are HIV positive and have a positive viral load. Those who are HIV status unknown, but who belong to a high-risk group. So these are epidemiologic groups in which the prevalence of HIV is higher than in the general population. And in Canada, that's MSM, or men who have sex with men, people who inject drugs, people who are from countries where HIV is endemic, and some Indigenous populations. And that really varies geographically. In Vancouver, there's not a high prevalence in our Indigenous populations, but certainly in certain parts of Canada, there is. Those who are considered to have low risk of transmissible HIV are those who are HIV positive and have a negative viral load, but have an STI at the time of the contact. And those who are considered to have negligible risk of transmissible HIV are those who are known to be HIV negative, those who are HIV positive but have a negative viral load and no STI, and those who are HIV unknown, we don't know, but they belong to the general population, so they're not one of the high-risk groups mentioned above. So just to point out one thing, I feel like when I see patients in the emerge, they either don't know the status of the source, and so we have to figure it out based really on demographics, or they say, oh, we had sex, the condom broke, he said, I'm HIV positive, but I'm on ARVs and my counts are negative. And the spirit of the guidelines, really, for those who are HIV positive but have a negative viral load, that's somebody who you can get the source, and they can go to a clinic or a practitioner, and they can confirm that they've had a negative viral load for 6 months. It's not just, the person who says, oh, I didn't know who he was, he said he was positive, but his counts are okay. That's still high risk, and we should be treating those as well. So similarly, the guidelines break down the risk based on the exposure into 3 categories: high, moderate, and low. And the data for this classification actually comes from a study that was published in the journal AIDS in 2014. And what they did is, for each exposure type, they did a meta-analysis of the cohort and cross-sectional studies that were available to come up with a summary risk. And a lot of these studies were done, or most of these studies were done, in the pre-HAART, or pre-highly active antiretroviral therapy era. So this number that you see here is the risk per act of unprotected encounter, unprotected sex with somebody who is HIV positive and not on ARVs. So if you were to have unprotected receptive anal sex with somebody who is HIV positive and not on ARVs, the risk that you would get HIV would be 1.38%. So things like condom use and antiretrovirals, that modifies the risk. Similarly, in high risk, we have needle sharing, and then it drops down fairly substantially into the moderate category for insertive anal sex or receptive or insertive vaginal sex. Of note, kind of a change from the CDC guidelines, if you look at the low risk, so we don't have numbers there because, I mean, it's theoretically plausible, I suppose, to get HIV from oral sex, but essentially your risk is 0. They did a study in Spain where they had more than 9,000 encounters and no transmission of HIV. And there are a number of reasons for that physiologically. So that's a change from the CDC guidelines, is that this is an essentially 0 risk scenario with oral sex. The one to think about on a case-by-case basis is the blood on compromised skin. So if you have open skin and the source is high risk to have HIV and there was a significant blood exposure, that is one that you might consider. And you can always talk to your ID specialist if you're not sure. So what you do is, once you've got your source risk and your exposure risk, you plug it into a 3x3 table. So for instance, if you had a patient who came in and they had unprotected sex with somebody who fell into the category of high risk for transmission of HIV, they should be started on PEP. In contrast, if they only had oral sex with that same person, they shouldn't be started. So all of this information, this is actually a picture that Tanya took for me. These are the tables from the CGEM article and the 3x3 table and risk categories. And those are hanging right behind Omnicell and Fast Track. So it's available there for you to reference easily. And then also Victor Leung and I have put this in for a mock-up, and so it will soon be available on the Spectrum app, I think that most of you have, for antibiotics here in BC. So if you've established that your patient does need PEP, there's some baseline blood work and testing that should be done. And since I started here 8 years ago, I guess that's all been in our automatic order entry set. So we get HIV serology, PEP A, B, and C. What hasn't been in the order set is baseline creatinine and ALT. And this is a new recommendation, and that's because the medications are hepato and renal are nephrotoxic. In particular, tenofovir should only be given to people who have creatinine clearances greater than 60. And that's one of the main drugs. So that's one of the issues that the IDC had been having, is that people are coming to them with no baseline renal function, and they have to, check that, and it prolongs finding out what the renal function is. So David Golnick and the IT team have added that, and it was actually supposed to go live last week, and I admit I haven't had a patient yet to check it on, but please do have a look for it there. It should be coming up as an automatic order entry on our screen. And then, of course, when you're talking about HIV transmission, you want to think about other STIs, so testing for syphilis, as well as gonorrhea and chlamydia. And then for the nPEP regimens, nPEP is a 28-day drug regimen, and it's to include 3 medications, 2 NRTIs, and 1 either protease inhibitor or 1 integrase strand transfer inhibitor, or INSTI. At St. Paul, so you can prescribe the full 28 days, and there's some studies actually that if you give the patient the full prescription, they're more likely to finish it. But at St. Paul's here, we have it pretty easy, and we've got our kits that we dispense. And our 3 medications, our 2 NRTIs are tenofovir and lamivudine, and then we have raltegravir, which is an INSTI. And so we've made a switch in our 3rd drug so that the medications are actually better tolerated by patients. And then for follow-up, If they want to see their primary care physician, that's fine. They can do that. But we also can offer follow-up at IDC to our patients. Anybody who's come after a non-occupational exposure can call them the next day, and they will see them and follow them up through their course of the medications. And all of this is, I should point out, it's all for consensual exposures. So at St. Paul's, if anybody comes in after a sexual assault, VGH is the center that follows them. And all sexual assaults should be offered PEP. And there are a number of reasons. There can be multiple assailants, so there can be trauma, so that increases the risk of transmission. So if you are at another site, all sexual assaults should be offered PEP. Just a couple points. That's the end of my nPEP, and so we were supposed to pass on to Mark Hall, but he was here at our last rounds. So a few things. PrEP has come out, and you're probably seeing it more and more in the emergency department with your patients who are on it. PrEP is a medication that it's tenofovir and emtricitabine, and it comes in a combined form as Truvada. There have been some studies, some Canadian and French studies combined, where they've looked at on-demand PrEP, and that seems to work well, but right now it is used on a daily basis, and that's what it's funded for in BC. So patients are on it, they take it every day, and it is covered by PharmaCare. Mark wanted us to point out a few things. You know, it's highly effective. If it's taken properly, it actually reduces the transmission, or it's 97 to 98% effective in preventing transmission. They've had a few referrals of patients who are actually started on PrEP in the emergency department, and they've asked that we don't do that. And the reason is that it's not an emergency, and that patients they have a number of tests that should be done ahead of time. They need to have a confirmed recent HIV test, because certainly if they're HIV positive, they want to start them on treatment and not just Truvada as a single agent. So patients are considered to be protected once they've had a full week of Truvada in their system. So if they come to you and they've been taking their medications and they've had it in their system for at least a week, then they don't need nPEP after an exposure. They are considered to be protected. The other thing he wanted to point out is that they've also had a few patients referred and who have been told to stop their PrEP. And there are very few reasons to actually stop your PrEP. But if you do find a reason, they have asked that you don't stop it until after 48 hours since the last exposure. So patients are considered protected if they've had it in their system for at least a week before their encounter, and they should take it for at least 48 hours after their sexual encounter. If they come outside of that, if they've missed 3 or 4 days, they should be started on nPEP if they've had an exposure and referred back to IDC to get on Truvada and figure out when they can switch from nPEP to Truvada. Well, that's it. Do you have any questions? Brian.
Giving, do we need to wait for that creatinine and then decide, or do we give them the 5-day starter vaccine that their creatinine is low?
Yeah, that's a good question. I think, to be honest, if I've had somebody who is, a young person, otherwise healthy, I haven't made them wait because they're usually seeing the IDC within a couple of days. It was more that, if they get to somebody 4 days later and then they draw creatinine and then they're going to follow up with them, they could be a couple weeks into it before they see that. Yes?
Been done with, I guess, like needle sharing incidents instead of sexual encounters?
Yeah, that's a good question. There's been one study that was done, and that was done in Thailand. And it's kind of confounded because, in Thailand in the study, they weren't provided with clean needles, which is different from, kind of confounds it a bit. And also they didn't discount that some of the exposures could have been through MSM sexual contact. So, there's kind of a combined category where it's sexual and needle use. So they do have other categories. They will also prescribe it. If you look at the guidelines, it can be offered to people who are heterosexual but in serodiscordant relationships, or MSM who are in serodiscordant relationships, so the partner is HIV positive, in particular if they don't use their ARVs regularly, and it can be offered to some people who inject drugs. The other thought is sex workers, but of course we don't have good research on that because it's not legal in Canada,
Right.
so it's hard to actually track that. But they are offering it, if you're using needles or sharing needles with somebody who's HIV positive, that's another category of patients. And, we can refer, PrEP patients can self-refer to Spectrum or HIM. They can refer to any of those clinics will offer it. You can also send them to the IDC. If you have a discussion, if you have a patient who's come now for their second round of nPEP, you can suggest to them, can I refer you on, and you can have a discussion about PrEP. Or Mark Hall, you can actually refer to him as well, and he'll see in his clinic.
Yeah, and I'm realizing that this isn't the point of these studies, but it's come up quite a bit just because I think a lot of our cohort ended up going to South Africa for trauma rotations.
Mm-hmm.
And people were like, well, maybe I should be on, because the HIV rate's maybe 70, 80% in some of those hospitals.
Yeah.
You're often doing chest tubes, lots of chest tubes, and hectic environments. So people are like, well, maybe I should be on PrEP. But I guess the research just really isn't, like, you'd still have to go on PEP if you were to have an elastic, I guess, eh?
Yeah, I think so. There's certainly not anything about that. Yeah. I'd maybe go with nPEP or with PEP, actually, if I was going to do a rotation. Yeah.
But like the evidence of PrEP.
No, there's no evidence. There's not. I haven't seen it come up at all, yeah. Andy.
Thank you, Shannon. I think it's great that you're going to have this on Spectrum. I always struggle to find the right table at the right time. I'm just wondering if another place that this would be is on the website. I think it would be nice that, because the table that I always struggle to find, which I think is useful to go over with the patients, is some of the numbers you gave. It's sort of the risk per exposure.
Yep.
And I think that's a good for sort of informed joint decision making. I think that's a nice table to go through with some patients. And
Yep.
It'd be great maybe if that was on our website.
Sure, we can do it. It's physically printed behind the Omnicell with the actual numbers per act.
But it's nice to print out something where it's electronic,
Totally.
so we can print it out for
Yep.
a patient. Is sort of a nice thing
Okay.
too.
I'll try and get that sorted. Yeah, Julian.
And we do the same thing for the Nurse Medicine Network.
Oh, yeah. Who do I send that to you? Okay. Todd.
There's any thought I can't reach it. For redoing the RAS tool, some people, I find it very useful. The numbers seem to have changed when you talk about the risk categories.
Yeah.
And so I mean, if you use that approach for whether I use it,
Yeah. Good. Good question. The most recent data is from this AIDS journal article where they looked at each exposure and did the meta-analysis and gave a summary risk for each. So it wasn't actually used in the guidelines. They used the categories of risk exposure and categories of source and then put it into a 3x3 table and gave very direct, yes, give nPEP, no nPEP.
There's two categories that a lot of our patients have been called, which is consider nPEP,
Mm-hmm.
right? And that's pretty much everything.
Yep.
Two people that are considered, and I like using the RAS versus some kind of RAS. It has actually having available somewhere, so I can consider it.
Yeah, I don't have those for you. They're not from, I don't have them, they weren't used in the guidelines, so I don't have them.
Because these get the numbers, just ask me.
We could look it up. Any other questions? Okay, great. Thanks, Ben.
Mike? Change the title, dude. Yeah. Put it. we can do, I can always bring up my computer and then what you can do, if it works for you, is, can you go with that? I can do that. In line with it?
Yeah.
So you'll have to move them both independently.
For sure.
Oh,
No,
you got it there.
Yeah.
I can't. Oh, I see. Right. Why isn't that then?
It says you have to use multiple.
That's great. Is there any way we can set that up here?
It doesn't matter. If I use this one.
Yeah, sure.
Sorry, it's complicated. Yeah, this one's okay. Sorry, guys. Technical difficulties. So I'm Mike, Merge resident here. I think I know most of you, if not all of you. And today I'm going to talk to you about some issues in wound management in the emergency department. Did an extensive literature review. This was kind of born out of my own limited understanding of what we do and what the evidence tells us we can do. And I was hoping today that I'd be able to answer a few questions for you, like, when is it too late to close a laceration? What wounds need antibiotic prophylaxis? What can we consider with respect to mammalian bites and repair? And what is the best practice for tetanus prevention? So let's get into it. We're going to talk about the golden period. So the golden period for wound closure seems to have originated from a study back in the late 1800s by P.L. Friedrich. He was a German physiologist, I think. He wounded hamster limbs and then contaminated them with sawdust and dirt, and then sutured them up over basic intervals every 30 minutes. And he demonstrated that all hamsters that had wounds repaired within 6 hours survived, and those that did not, well, they died. And this became the basis of wound management up until World War II and beyond. So we were using hamster literature to kind of guide what we did. And you flash forward about 100 years, Burke, in a busy Jamaican study or emergency department, published a study that looked at all comers with whatever wound, wherever it was, and they sutured them up. And they showed up to 19 hours after initial injury, they had adequate healing, no increased risk of infection. Now, one of the study's limitations was a 50% loss to follow-up rate, and they also used the same equipment that was unsterilized between patients, and they still had equal infection rates despite that. Now, what he showed was that these lacerations were not limited by 6-hour repair rule, and another interesting factor was lacerations to the face and to the scalp could be sutured 1 to 2 days later, provided they weren't actively infected. Now, in 2010, Vanderbar set out to vanquish the golden period once and for all. So he had a study, a prospective cohort study evaluating the 6-hour repair rule. This showed any laceration sutured after 6 hours and up to 19 hours had an infection rate of 6.5% compared to the baseline 9% in the under 6-hour repair group. They were unable to adequately power the study to see beyond 19 hours. Only 5 people presented beyond that time frame. But they did note that major factors for wound infection were not timing to suturing, but rather patient's age and location of the wound. So patients over the age of 40 and wounds to the lower extremities had a significantly higher increased risk of infection. Now, a large multi-center study by Quinn, published in 2013, showed the timing to presentation was not a risk factor for wound infection. The goal of this study was to evaluate various risk factors, and they found several, but time to presentation was not statistically significant. After analysis, they determined wound length greater than 5 centimeters, diabetes, a non-head and neck location, and moderate to heavy contamination were the risk factors for infection. So what can we take home from this evidence? I think the most cited cutoff for wound repair is 19 hours, so 19 is the new 6. Head and scalp injuries could be pushed even further, 24 hours or more, provided they're not actively infected. And then we have to consider risk factors, so patients with an age over 40, non-head and neck wounds, especially lower extremities, diabetes, and immunosuppression, and then wound length greater than 5 centimeters. And obviously hamsters, they don't heal quite the same as humans. These are two survivors of Friedrich's study. They're not actually. Anyways, mammalian bites. This is a whole different beast altogether. Sorry for the pun or joke. There's very conflicting evidence out there. PoCUS et al. Performed a randomized control trial published in the journal in 2014. They looked at approximately 170 patients with dog bites. All comers had an 8% risk of infection, equal among those who underwent primary closure compared to no closure. What they did notice is that patients who got primary closure within the first 8 hours of presentation had a 4.5% risk of infection, and they also showed that primary closure had a much better secondary outcome of cosmesis. A second study, Mamaris et al. From the Archives of Emergency Medicine back in 1988, a little old, I'm sorry for that, published a randomized control trial of approximately 100 patients with dog bites that were randomized to suturing versus no suturing. And again, they found equal infection rates between primary closure and non-closure. They did note that 13 patients overall developed infections, and 9 of those were patients presenting with hand infection or hand lacerations. They did report, much like PoCUS, that cosmesis was significantly improved with primary closure. They also noticed that a trend occurred in infections, a spike in infections if wounds were sutured after 10 hours. Shannon et al. Published a prospective observational cohort study in the Academic Emergency Medicine that had 145 mammalian bites. They had 88 dog, 45 cat, and 12 human. All patients were randomized to primary closure, again, no closure. They had 8 total infections, or an infection rate of approximately 6% with all comers. They had some obvious limitations that they identified, including non-standardized cleaning, non-standardized antibiotic prophylaxis, but they found no difference between infection rates despite type of cleaning, type of antibiotic prophylaxis, or no prophylaxis. Overall, that article suggested again that despite its limitations, infection rate and cosmetic outcome were acceptable for primary closure of all types of mammalian bites. Now, in 2014, a meta-analysis by Cheng, published in the Journal of Plastic, Reconstructive, and Aesthetic Surgery, with over 1,000 patients, and it actually referenced those 2 previous studies, showed no difference between infection rate between primary and no closure. So there was a recurrent theme with all of these studies that primary closure wasn't associated with an increased risk of infection. But I think one important thing to note is that not all bites are created equal. There are several risk factors to consider when approaching mammalian bites, and this was actually published in the American Family Physician Journal by Ellis and Ellis, providing a really great summary. So any wounds that present involving the hand, bites overlying compromised venous or lymphatic structures, bites near or in a prosthetic joint, cat bites, crush injuries, puncture wounds, diabetes or immunosuppression, and then delayed presentation. So they quantified that as greater than 6 to 12 hours for extremity wounds, greater than 12 to 24 hours for head and face. So if any of those risk factors are present, primary closure may not be the best idea. Now, a recent article published in CMAG in 2018 summarized 5 tips for managing mammalian bites, and chief among them were irrigation and wound debridement. They also reported that only lacerations or wounds to the face and genitals should be primarily closed. Otherwise, we should use secondary intention or delayed primary closure. I don't think that statement necessarily lines up with the available research. And when I looked at their resources, they were previous chapters in trauma textbooks and not actually the randomized control trials that we've previously discussed. So what can we take away from that with respect to mammalian bites? Well, I think they're different, obviously, than simple lacerations. Based on the available evidence, suturing dog bites would be acceptable, but we need to pay attention to the aforementioned risk factors. Timing to closure seems to play a more important role, And if you see people presenting after 8 to 10 hours, there may be a debate there as to whether or not you want to close this wound. Risk factors, again, should be considered before suturing. And anytime a cat bite or human bite comes in, I wouldn't be jumping to suture those closed, given the high-risk nature. But if cosmesis is important, there is some evidence out there that says we can. Which actually brings us to my next point, antibiotic prophylaxis. So there are many different people that come to the emergency department. They have many different wounds. They have complex medical histories. And all of that will kind of guide what we do with prophylaxis. When sifting through the research on antibiotic prophylaxis, there's a number of studies that show simple lacerations, even those to the hand, do not benefit from antibiotic prophylaxis, but rather vigorous wound debridement and irrigation. A recent meta-analysis by Murphy et al. In 2016, published in the British Journal of Surgery, documented that even those hand lacerations that require surgical intervention do not benefit from antibiotic prophylaxis. Now, there was a benefit seen in higher risk wounds, such as those occurring in immunocompromised patients, puncture wounds, crush injuries, open fractures, joint involvement, or grossly contaminated wounds, or those patients who come in after a significant delay greater than 18 hours. So moving on to animal bites and antibiotic prophylaxis, there was a Cochrane review published in 2001 and again revised in 2008. Now, the review, based on available evidence, concluded that there was a benefit to antibiotic prophylaxis in human bites and bites to the hand, but it concluded that animal bites, so dog and cat bites, did not benefit from antibiotic prophylaxis because they had equal infection rates despite the use of antibiotics. Now, there was a critique of this Cochrane review that was published in 2012 by Henton in the Journal of Surgery, I believe, Journal of Hand Surgery. And he pointed out some significant flaws with the available research that was used for that Cochrane review. Namely, all of the studies that were included used antibiotics that we don't use for prophylactic treatment or management of infections. They had very narrow spectrums. They didn't have appropriate anaerobic coverage. And he concluded that based on limited research, vigorous debridement and irrigation with delayed primary or secondary closure coupled with antibiotic prophylaxis should be your standard of care. And again, that felt a little heavy-handed. Based on currently available guidelines, such as those published in Bugs and Drugs, prophylaxis for mammalian bites should generally be started within 12 hours if the wound has, or if the patient is immunocompromised, asplenic, has advanced liver disease or signs of infection. And then other high-risk wounds like puncture wounds, injuries to the hand, foot, face, or genitals, or moderate to severe contamination. Now, an observational cohort study published in 2015 by Tabaka also supports prophylaxis use for dog bites that should be given if the wound is considered a puncture wound or any wound that is primarily closed, as those were the two factors that they found linked with increased risk of infection. A follow-up study by Jandal, published in 2016, showed that risk factors for infection in mammalian bites included puncture wounds, delayed presentation, and wound length greater than 3 centimeters. So what do we take away from that? Simple lacerations do not require antibiotic prophylaxis. High-risk lacerations, such as crush injuries, puncture wounds, open fracture or joint involvement, grossly contaminated or delayed presentation greater than 18 hours, would be considered high-risk wounds, and those may benefit from antibiotic prophylaxis. With respect to mammalian bites, human bites should receive prophylaxis. Cat and dog puncture wounds, wounds larger than 3 centimeters, or those primarily closed, should receive prophylaxis. In this case, amoxiclav twice daily for 3 to 5 days would be the available choice. So moving on, I'd like to review tetanus immunization and tetanus itself. Tetanus is a nervous system disorder caused by Clostridium tetani, which is a toxin-producing gut anaerobe found in soil. It forms tetanospasmin, which travels to the nervous system, causes painful muscle spasms, and hyperstimulation of the sympathetic nervous system. Now, the incubation period for tetanus is 3 to 21 days. with longer incubation periods being associated with milder disease. Without treatment, tetanus has approximately a 50% mortality rate. Again, more survivability with longer incubation periods. Now, treatment is aimed at halting toxin production, neutralization of the unbound toxin, active immunization, then managing the sequelae of the disease itself, including the hyperstimulation of the sympathetic nervous system and apneic periods. So we treat, we halt the toxin production with wound debridement. This is kind of cardinal to every wound that presents. Administering Flagyl, 500 milligrams every 8 hours for 7 to 10 days. This is if you're diagnosed with tetanus itself. We neutralize the unbound toxin in the blood with tetanus immunoglobulin, and then we provide a full vaccination series as required once the diagnosis is made. We manage the sympathetic complications with benzodiazepines, magnesium sulfate, and potentially intubation if they require it for apneic periods. Now, I'd like to briefly review tetanus immunization, which is one of the most successful immunization programs ever implemented, and then what we can do with respect to wound management. So, vaccination schedule for those that have received less than 3 doses throughout their life. Your last dose is typically, I think, grade 9, so about 14 years old. Mandates completion of the series as required, and that the first and second dose should be separated by 4 weeks, and the third dose should be given 6 to 12 months later. So in this case, we have a table that outlines tetanus status and wound status. So clean wounds and tetanus status. If we have a clean wound and someone's received less than 3 doses or an unknown amount of their tetanus vaccination schedule, we give them a tetanus booster. If they have had their 3 doses, then we can give a tetanus booster if it's been greater than 10 years since their last dose. So in BC, I think the third dose is when you're 14. So anyone presenting after the age of 24 would probably benefit from it unless they've had a later scheduled dose. Now, with respect to dirty wounds, those are anything contaminated with dirt, soil, feces, saliva, avulsion wounds, puncture wounds, wounds resulting from missile injury, which I don't know how applicable that is here, crush injuries, burn injuries, or frostbite. With respect to dirty wounds, anyone who has less than 3 doses or an unknown vaccination history should get their tetanus booster, and they should also receive tetanus immunoglobulin, which is 250 milligrams. And they should be administered in opposite sites. Now, if someone presents with an adequate vaccination history and a dirty wound, they just need the tetanus booster if it's been less or more than 5 years since their previous dose. And a special note should be made, anyone who's severely immunocompromised or has HIV and presents with a dirty wound, they, based on available guidelines and evidence, should receive tetanus immunoglobulin as well as a tetanus booster, regardless of their status. So what can we take home from that? Tetanus has an incubation period of 3 to 21 days. If you're diagnosed with it, or if you diagnose someone with it, you treat with wound debridement, tetanus immunoglobulin, Flagyl, beta blockers, magnesium sulfate, and airway management. Clean wounds require a tetanus booster if it's been greater than 10 years since their 3rd dose. Dirty wounds require a tetanus booster if it's been more than 5 years since their 3rd dose. If you're in doubt, you can give the booster. And if it's a dirty wound with incomplete vaccination status or the patient is immunocompromised regardless of vaccination status, tetanus immunoglobulin is required. All right. That's it. I'm done. Thanks for listening. Today's my wife's birthday, by the way, so we can all wish her a happy birthday. She's not here. And those are my tiny references. Any questions? Connor. Oh, I got one.
Sorry. Mike, I was just going to ask, in terms of the immunocompromised, who are you actually going to give tetanus immunoglobulin to? It seems like that's pretty broad.
I know. So when I looked at the reference for it, they kind of blanket statement immunocompromised. I think that it would have to be like not knowing enough about it. I think they would have to be poorly controlled diabetic with signs of end organ dysfunction. Those that have HIV that I'd have to look more into it. I can't give you a definitive answer, but I think poorly controlled medical conditions that would delay wound healing or increase your risk of systemic infection. So they don't really quantify that. I think we have to use our judgment. But if it's been say somebody comes in from the farm and they have dirt that you can see in the wound, that I think that would constitute dirty. But if somebody tells you they were, cutting fruit in their kitchen with a sharp knife, then that wouldn't necessarily make you jump to consider it a dirty wound. And this is where our own kind of clinical acumen and decision-making skills come into play. But I don't have a good answer for you. Sorry, Connor. Yeah.
Oftentimes in Emerge, we don't have a good answer for these cases. And so this really brings up the point of making a shared decision with the patient about how you want to manage this. So that's what I will do in a lot of these cases, especially the dog bites, where I'm like, you may not need antibiotics, but it's kind of like, let's make a decision together. And especially, again, with immunocompromised patients.
Mm-hmm. What do you see typically happening? Do more people end up taking the prophylaxis if you offer it to them?
I tend to talk people out of it a lot of the time, but I just document that it was a shared decision. Very important.
Thank you.
The last 3 or 4 years after studying the states looked at the length of immunological response to tetanus, they recommended decreasing tetanus vaccination in 10 years, perhaps 30 years. The UK and the World Health Organization.
Okay.
Have you ran into anything in your research for Canadians or trends in that direction?
I didn't see anything. This was the most up-to-date information that I had for Canadian guidelines. But that would be, I do think that what was referenced a lot was people who have had their 3 doses, you're typically, you're very low risk of getting it. It's when people haven't had a full course or they have, they're very immunocompromised. Those are the ones that are going to get it. But it's more common in developing countries where they have inadequate vaccination and then they don't debride their wounds as well. They don't irrigate them quite the same. So.
Yeah, I get into a shared decision-making discussion as well, rather than saying, we have to get tetanus every 10 years. I'd say, look, this may be no benefit for you if you like this. It's an option. I think a lot of patients like to prophylax antibiotics, given the option.
Mm-hmm.
So, why don't we wait and see kind of thing? And again, watching that's a shared decision.
Right. Thank you. Anyone else? Thanks, guys.
Vaguely. No.
Be all dynamic.
No. Thanks.
Section PC to this one.
Oh god, that doesn't look the same. I took a picture of what it's supposed to look like. This.
Oh, it says this one. Which?
Oh yeah, that's right.
Yeah, you might want to plug it in.
Oh, and then it'll change to look like that.
That thing. Oh, this one here. Blu-ray. There.
No, laptop HD.
Is that yours?
Yeah.
Because I can't see that.
Yeah, I don't know if it's working yet. Oh yeah, it's great. I can go slow.
Okay, I'm Laura. I'm one of the current ultrasound fellows, and today I'll be talking about ultrasound-guided femoral nerve blocks for hip fractures. So hip fractures are common in the ED, they're common in the elderly, and they're challenging to treat because of the side effects of NSAIDs and opioids. Untreated pain leads to more delirium, longer length of stay, and delay to ambulation and function. Regional anesthesia can be a helpful adjunct or alternative in treating pain. So is this something that we should be doing more consistently? Femoral nerve blocks are not a new trick. So they have been used as early as the 70s. And in the 80s, there were papers published showing they're a safe, effective, and easy to learn technique, even in the emerge. So there's different techniques. There's the classic femoral nerve block. There's the 3-in-1 block. And there's the fascia iliaca compartment block. More on that later, but for now, I'm just going to use femoral nerve block as an umbrella term. So I'm here to tell you that femoral nerve blocks are efficacious, safe, feasible, and not that hard to learn. Now, at St. Paul's, the emerge docs are fortunate to have the anesthesia consulting service available for femoral nerve blocks, and you can call them anytime, but primarily they're available Monday to Friday. They do want to be called nights and weekends as well. So you might have to do it at night though, and many of you work in other locations as well. So this is just a short talk to briefly cover the literature, very briefly, and just touch on the practicalities of the procedure. So this is just hopefully to pique your interest, to get more interested and more involved. So what are the benefits? Much of the literature on femoral nerve blocks is from the anesthesia world, and there are limited RCTs in any setting. They have small numbers. There is little blinding. It is challenging to blind when you're doing blocks, and there's a lot of heterogeneity in terms of technique. So even whether they're using ultrasound versus just landmark technique or nerve stimulators, especially with anesthesia. The most recent ED-focused systematic review was in CGEM in 2016. It identified 9 RCTs comparing a single-shot femoral nerve block to standard analgesia. ER docs were performing the blocks in half of the studies. So in 8 out of the 9 studies, they did show that the femoral nerve blocks improved pain scores compared to standard treatment. And as a secondary outcome, there was also in 5 out of the 6 studies, a reduction in the amount of opioids used in the femoral nerve block. So in most of the studies, you have the block, but if you need it, there's rescue analgesia on top of it. So notably, the one study that was found to be at low risk of bias was in the ED setting, and they used ultrasound, and they actually used sham injections. So it was a well-designed study, and they again found decreased pain in the block group. And it was complicated the way they looked at it. They looked at the 4-hour mark, and basically in terms of the area under the curve, the change in the pain scores at the 4-hour mark, there was a statistically and clinically significant reduction. And also there were way fewer patients, so 5 out of 19 compared to 14 out of 19, requiring rescue opioids. And the total dose of opioids the people that got femoral nerve blocks needed was also lower. So just a brief glance at their visual. At the top, there is standard treatment, not much change in pain, and then with the femoral block, a great reduction in the pain scores. So in terms of delirium, there's quite limited studies, but when it is reported, there is a reduction in both the incidence and the duration. One study even showed a benefit in ambulation and function at post-op day 3 and at 6 weeks. So, not surprisingly, ultrasound does make it more successful. So this makes sense. You're more likely to get close to the nerve, but not so close that you hit it, and you're less likely to hit arteries and veins. So this has actually been shown in several studies, with one study showing improvement in block success with ultrasound from 47 to 82. But is this feasible in the ED setting? So there are several studies showing that EPs can learn and successfully perform femoral nerve blocks without excessive training. So 20 minutes in one study and 30 minutes in another. And especially in the last few years, there's many papers out on implementation studies starting to do femoral nerve blocks for hip fractures in EDs. And there's even some studies looking at pre-hospital femoral nerve blocks. But what about the complications? So, of course, a big one is local anesthetic systemic toxicity, or LAST. So none of the previously mentioned RCTs reported any incidence of LAST, but they're not powered to detect harms. So one of the recent implementation studies had one episode of non-fatal LAST in 1 out of 1,500 blocks. And if we look at the observational data, there's a registry with over 22,000 patients, and they found that the incidence was less than 1 in 1,000 and way less likely when you're doing lower extremity blocks, so including femoral nerve blocks, and way less likely if you use ultrasound, so actually reduced by 65%. Now, some even suggest that you can try lidocaine when you're first starting out with femoral nerve blocks, because much less likely to be cardiotoxic to get LAST. So that's one option. What about nerve damage? So there's no consistent reporting of iatrogenic neuropathy, and there's a big range of incidents reported, all the way from 2 in 10,000 up to 4%. Now, 4% sounds bad, but it's difficult to distinguish neuropathies from the regional spinal anesthesia that they get later, or even the surgery itself. And most of the neuropathies that were reported were paresthesias that went away within a few months. So again, with ultrasound, it's easier to avoid the nerve, so this is definitely the recommended technique. Arterial venous puncture is reported at 1 per 2%, and infection is quite rare. There is no evidence to suggest that regional anesthesia will mask a compartment syndrome. This is theoretical at this point. Today, we're mostly talking about falls from standing. So if you have really significant mechanism, you might want to reconsider, talk to your consulting services about blocks. So in general, the evidence isn't amazing, but overall, based on the best evidence that we have, it does consistently look like femoral nerve blocks in the ED setting are effective and safe as an adjunct or as an alternative for pain, and especially with ultrasound. Okay, so those 3 different types of blocks. Which of them is best? So when you're looking at the hip, the innervation is from a whole bunch of different nerves, but the femoral nerve is the big player. So the femoral nerve block is just like it sounds. You're getting the anesthetic around the femoral nerve. In the 3-in-1 block, this isn't in vogue right now, but basically you inject in the same spot and you hold distal pressure, and then you hope that the anesthetic will spread cephalad. Now, in the fascia iliaca compartment block, the idea is similar. So you want to put a large volume of anesthetic under the fascia iliaca. That's your fascia over top of your iliopsoas muscle, with the intent of it spreading medially and laterally to involve your lateral femoral cutaneous nerve and your obturator nerve. So in reality, these blocks are really quite similar. And there's actually been several papers published showing that they're equivocal in terms of efficacy. So basically, your plan is to get under the fascia iliaca and lateral to the nerve, regardless of what kind of block you want to call it. They're quite similar. This is your sensory innervation from the femoral nerve. So contraindications. There's no clear guideline on anticoagulation. So most agree it's not a hard contraindication unless the patient's super therapeutic. It's important that the patient can communicate if they're having paresthesias, because that would suggest that you're in the nerve, and you need them to be relatively still enough for the procedure to be safe. You don't want to do blocks if there's pre-existing neuropathy, infection, or compartment syndrome. And for EPs, it's best to avoid previous surgery, so if there's hardware, metal in situ. Okay, so now for the actual approach to the procedure. You do want to use the cardiac monitor, and it's recommended to use it until 30 minutes post, based on the peak time of bupivacaine. So in terms of the anesthetic, bupivacaine is most commonly used, and you want to try to use at least 20 milliliters of fluid. You want to calculate your max dose every time. So for bupivacaine, it's 4 milligrams per kilogram. Lidocaine is 2. And it's advisable to check your dose every time. So this is a great website where you can just check your dose, highlandultrasound.com. And remember, it can take 30 minutes or longer for the peak effect, and your goal is pain reduction, not getting rid of it entirely. Now, especially for the fascia iliaca compartment block, you're going to have more effect if you have a larger volume. So once you figure out the dose you're going to use, you can add normal saline, and that'll increase your spread. In terms of equipment, the degree of sterility is somewhat controversial. So definitely prep the patient, wear sterile gloves. Some are using a Tegaderm instead of a sterile probe cover. And you want to use sterile gel, so you can use the individual lube packages or the sterile gel itself. And it's recommended to use a 3.5-inch spinal needle. It's nice if you have an assistant, so they can do the aspiration and injection. So if you can attach it with some tubing, so you set it up like this, it makes it easier for everyone. You want to know where your intralipid is. And yes, it is in the Umni cell, in acute and in trauma. So you want to scan your patient before you get them prepped. So the position is going to be supine, the hip slightly flexed and externally rotated. And you want the machine on the opposite side of the bed, makes it way easier. The external landmark is the inguinal crease. So this is just like putting a fem line in. And you want the probe marker to the patient's right. Okay, so starting to look at the ultrasound anatomy, you want to pull out your naval mnemonic. So looking at the right leg, this is lateral, and this is medial. This is the artery. It'll be non-compressible, pulsatile, and this is your vein. And then just lateral to the artery is your nerve. Often, not always, it's a triangular shape, and it's hyperechoic, so it's white. And sometimes it has a bit of a honeycomb appearance to it. But always it's going to be lateral to the artery. If you're having trouble finding the nerve, you can try adding some pressure and little tiny gentle sweeps that can make the nerve pop out. So again, here's your artery. This is your nerve here. And the next thing you want to start noticing is your iliopsoas muscle. So that's that dark thing, out even more lateral. And the fascia iliaca is the first white line if you go up from the muscle. So you find your iliopsoas out laterally, and then on top of it will be lying your fascia iliaca. So again, artery, here's your white nerve, the muscle with the fascia iliaca on top. Your goal is to get under this fascia iliaca here. If you get your anesthetic on top, it's going to have difficulty diffusing to the nerve, and you won't have a good effect. So for the femoral nerve block, you're just getting close to the nerve. And for the fascia iliaca block, this is your fascia iliaca, and basically what you want to do is get underneath it. So you find your artery, you find your nerve, and then you slide out more lateral. And what you want to do is basically just get a really good view of your fascia iliaca. You'll notice sartorius coming into view here, but the key is really just this white line here, finding your iliopsoas and the fascia iliaca. In terms of the actual injection technique, you want the most painful part is the skin. So you want to put a little lidocaine wheel in as per usual where you're going to go in. It's the in-plane technique that's recommended. So that's where your needle comes in parallel to the probe around a 30-degree angle. Now you're going to go in with little tiny increments, 1 to 2 centimeters, and you want to know where your needle tip is at all times. It's surprisingly easy to lose track of your needle. So one thing you can do is something called Hydra Localization, but basically you just do a little tiny test dose, like a half cc, and you'll see black fluid come up on the screen. And that tells you where your needle tip is. And what you can do is even just start with saline until you get to the right spot, and then you can switch over to your anesthetic. So basically what you want to do is get under, again, this fascia iliaca here. And when you put in the black fluid, you want to see it pushing the muscle down right under that white line, the fascia iliaca. You need to stop if you're getting any resistance or paresthesias. And you can put your whole, once you're in the right spot, you just want to put in 5, aspirate, put in 5, aspirate, and get your whole volume in that area here, close to the nerve, out lateral, under the fascia iliaca, on top of the muscle. When you finish your block, of course, it's important to communicate this to the consulting services, write a procedural note, but also write on the patient's legs. You can use a wound marking pen and write the date, time, and dosage of the block right on their leg. So let's make this a bit more clear with some videos. This first one here is a right leg, like in the previous photos that we've seen. So we've got lateral and medial. So you can see the needle coming in from lateral, and that's what it looks like when you're injecting fluid. You see they're pushing down the muscle right under the fascia iliaca there. In this next one, we're flipped around now. And so this is a left leg. So you've got lateral on the other side, flipped around. And again, you can see the needle coming in, injecting. So you see the black fluid, and they're right next to the nerve there. The nerve's right here. This is your artery. This is lateral. In this one, they've put in a little bit of anesthetic first, so it obscures the view a little bit. So this is your nerve here in this one, and your vessels are out over here. So you see them coming in from lateral. You see some black area showing up. They're putting some fluid in. They realize this is the fascia iliaca here. And so remember, you want to get under the fascia iliaca to get good effect. And so then they go in a little bit deeper. Right there, and then you see they're right close to the nerve. Now, all 3 of these are actually pretty close to the nerve. When you're first starting out, it's advisable to stay even further from that. So this last one here is a good example of that. So in this one, the narrator has said that the nerve is over here, so you just can't see it well in this one. So they're nice and far away from it, coming in laterally. This is more of a classic fascia iliaca block. So you got your fascia iliaca up here, this is your muscle, and you see that nice spread with the fluid pushing the muscle down. So the key points for the procedure itself are know where your needle tip is at all times, stay away from the nerve, just stay lateral to it, and get under the fascia iliaca for a good effect. Thank you to these awesome people. And in terms of next steps and resources, this is just obviously a super short talk to pique your interest, but like any skill and knowledge training are essential. So I've spoken to anesthesia while preparing this. They're super open to teaching people blocks in the emerge. So if you're consulting them, ask them if you can watch them do the block. They're really open to emerge people getting more involved with their QI project. So that's been up and running since February, the consulting service for femoral nerve blocks in the ED. And there's lots of ultrasound keeners lurking around, so you can ask other ERPs. And then there's tons of excellent online resources. So the New York School of Regional Anesthesia, lots of the images are from them. EM Cases has a journal jam on femoral nerve blocks. 5 Minute Sono has great videos. If you're into an ultrasound podcast, if you're into more of the literature, GEL is a podcast on ultrasound papers. And then Mike Stone, who is a block guru, has great videos on Vimeo. Thank you. Any questions?
Thanks to all the speakers today. I don't have a talk per se, but I got a few minutes left here, and just wanted to give this is mostly just for the staff who will be presenting, especially within the next year in grand rounds. So I sent out a Survey Monkey recently just asking questions about what topics people want to be hearing in the next year. With a bit of an explanation of some of the changes that are going to be happening. Ideally, that we're going to be more proactive in kind of organizing what topics people are going to be doing ahead of time. So ideally, and this is in the attempts to reduce repeat topics across sites where residents are seeing, say, 4 rounds in a month, so that we're not presenting the same topics and they're not sort of wasting their time on their education hours. The other reason I think is so that we can more clearly assess, with foresight, what the topics are that we really want to hear about and maybe even are pertinent to our group. So part of that survey, I got a list that isn't really very big. people I think are, so busy it's hard to really spend a lot of time to send all kinds of thoughts of what great topics we could have in the next year. So I've got a reasonable list of 10 to 15 topics that people want to hear in the next year, and we do only have about 10 ground rounds in a year. So it's not a bad list, but what I will be doing in the next 4 weeks or so is trying to track down all the people who will be presenting and requesting that you either choose a topic from the list that has been already created or come up with a topic that you would like to be presenting on in your rounds presentation in the next year. So we at least have that predetermined thing, and it doesn't mean it's set in stone, that those things can change if you want as we approach your date. But it's important that it's going to have to be cross-referenced with what all the other groups have already chosen by that time. So as we speak right now, the other groups are, because they've always done it this way, is they're more sort of ahead of time organizing all the speakers for the whole year, and they don't have a predetermined schedule like we do either. So they're sort of choosing who might be a good person to present X topic. But whereas here, I think we just, we'll have to find people who want to do the various topics, or you choose your own. But like I said, it needs to be cross-referenced. So as we leave it later, it's more difficult to get those topics. So I just wanted to open, there's not a lot of staff here today, but just any questions people have or concerns about that method of doing things. Sounds okay? Okay, great. Thanks a lot.